Good day, dear viewers. In this lecture, we will discuss methods and equipment used for airway management. First of all, let's discuss some basic definition for the topic. The airway is the windpipe which is from the nose and mouth through all the upper and lower airways and to the lungs. So this is the actually part of the body where the air is conducted from the outside to the inside where it does the gas exchange. The airway management is placing some airway tube inside the patient to protect the airway so that they will be operational. Why they are not operational? We have some indications for the airway management procedures. First of all, the patient is in acute condition when he is unable to breathe himself, and we have to provide artificial ventilation, like in case of severe coma, in case of cardiac arrest, and so on. Then there may be some damage done by the trauma to the airway, like in case of some burn or some obstruction by blood or some other masses due to aspiration, for example. So in this case we have to provide some protection from these foreign objects and maybe remove them if possible. Then it's necessary for a patient who is undergoing a procedure under general anesthesia. So it's generally almost every patient who is going to the operation room for general anesthesia and operations. And also some cases where patient is able to maintain breathing, but he or she has a severe respiratory insufficiency syndrome. So in this case we also have to kill the natural breathing with our medications and provide the artificial one. When we talk about the airway management, we have to remind some history of the process. First of all, the intubation of trachea was discovered when it happened after the World War II. They decided that many patients are undergoing some severe procedures and they do have some loss of consciousness, some coma and respiratory problems, and that's why we do have to invent something. There are two basic problems which were discovered. First of all, there is a risk of the tongue slippery. You know that we do have a tongue. The tongue is basically a group of muscles and together with other soft tissue and muscle structures, it's forming the vocal apparatus and the airway itself. And if everything is normal, we do have a basal tonus, and in this case everything is working fine, so we can talk and we can breathe normally. But if the patient is relaxed due to cardiac arrest, coma, or other severe injury or condition, in this case all the muscles are getting relaxed, and if patient is lying still, for example he's lying on his back, in this case this relaxed tongue gets larger, the shape changes, and it can obstruct the airway by itself, so it just falls down, completely obstructs the throat, and the air is not able to come inside. So this is the first thing. And the second thing is the risk of aspiration. When the patient is also in these types of states, he or she may develop the aspiration. That's the process when the contents of the stomach are just floating, going up, and they somehow get to the throat, and some part of these contents may get inside the airway pipe. Of course, they're causing troubles. If there is a big amount of contents swallowed and some of them, really big amount is going inside the airway. In this case, patient may die due to complete airway obstruction. If there is a small amount inhaled inside the airway, the aspiration pneumonia may develop due to the inflammatory reaction on these foreign objects. But this is not enough to cause the death of the patient, but of course it's bad, it leads to complications which need to be treated. And in some cases, these complications may be fatal if the condition of the patient is worsening due to the development of this pneumonia. So, to processes and to somehow deal with them, our scientific teams and rescue teams, they started to use the intubation tubes to completely seal off the airway from the outside and from the contents of the stomach. So this is the intubation tube, and it looks the same as it used to years ago. Of course, the materials are changed, so this is like thermoplastic. So if it's warm, for example, inside the body or on the sun, or somehow it gets soft, this helps us to prevent injuries related to the prolonged stay of the tube. But still, this may result in some problems while inserting the tube, but more on that later. So they invented this tube. There was a time when there were special medical professionals. It's a subtype of nurse which was called the intubator. It was a nurse which was responsible only for the tracheal intubation, and before the operation day or in the emergency department, they just were called when we did need the procedure, when we did need the intubation. But that's really a problem, and we of course needed some alternatives, and that's why they started to invent other devices which are more easy to use, which are more common to use, and you won't need some specially trained staff, especially for the procedure. And that's why now we have a huge variety of other devices. We can divide them into groups. So the first is the endotracheal tube, which I've shown you before. This is the absolutely best thing, and other devices are called the supraglottic device. So they are not getting inside the trachea, but they are going somewhere upper in the upper airways. So they are not as effective as an intubation tube, but they are much more simple to use, and in some cases this is a decent alternative. So let's look at them all one by one, discuss indications and abilities that they give. Firstly, I will show you all the devices, and then we will look on the patient on how do we install them. First of all, we have this Oropharyngeal tube, or the S-type tube, depending on the language generally. So the scientific name is Oropharyngeal tube. According to the name, this one is installed inside the mouth of the patient, and when it will be installed, this end, the inside end of the device, will press the tongue, so it will prevent the tongue slippery. And if you can see, there is an empty part inside, so the air will come also inside this tube. Why is this device useful? It's cheap, so you may find it in a big variety of crash carts and first aid kits. It can be used by anyone. There are different sizes of these devices. For example, this one is for adult use, and if you let me, there are devices of different sizes. You see that there are different colors and they're smaller. For example, this one green is for children. You can compare its size to the red one for adults. There are even larger ones like this one. So we get the idea. They are transported together in a set, and when you look at the patient, you may select the correct size. How do you do that? You place the tube near the patient so that this outside part will be on the level of the teeth, and the inside part must be on the level of the angle of the jaw. So this one is all right for me, for example. And of course, you select which one is needed, then you insert it inside the patient. More on that later. Then more complex devices. You see, the Oropharyngeal tube only works with the tongue. It does not prevent any aspiration. So that's why we needed a further development. This device is called the Laryngeal tube. Laryngeal is from the word larynx, so it's a tube which does do something with the vocal cords, but of course it doesn't come directly inside the vocal apparatus. There are 5 sizes of these tubes. This is size number 3. The size is written on the tube, and they come together with a big syringe, which is used for inhaling the cough. This thing is universal. This is for inflating some coughs. And when you want to insert this device inside the patient, you just push it as far as you can until it stops. So this will be the inside part. This will be the outside part, of course. So it will stay somehow like this in the patient. And then you inflate the cuffs. There are 2 cuffs that are inflated together, and you can imagine, if you remember the airway correctly, the anatomy of the airway, I mean, they will be in the patient, so this way, so the inside part will, when inflated, will obstruct the esophagus, and no contents of the stomach will come up. Then this upper, more outside cuff will block the tongue, so that the tongue will not slip. And it leaves us with this secure, rather secure area, and when you blow the air inside, you blow it here in this yellow connector, and it comes here from the side. And where is that in the patient? So here we have esophagus, here we have the mouth, and here we have the entrance to the vocal cords. So somewhere here the epiglottis, and the trachea goes down below. And when you do that, the air has nowhere to go but inside the airway, and you can ventilate patients with this device. The advantage is that we work on both the tongue problem and the aspiration problem. The disadvantage is that sometimes it does not seal the airway correctly, and thus there is a risk of aspiration anyway. In some tubes there is an additional port which is used for the gastric tubes, so you can wash the contents of the stomach. This one unfortunately does not have this port. Then there is a laryngeal mask. Looks like this. Also there are different sizes. This is size number 5, so this is the biggest of models available. So this is for a large adult person. Oh, by the way, the laryngeal masks are measured by the patient's height, and laryngeal tubes are measured by the patient's weight. When you use the tube, you will always have the information written, so it will generally say size number 5, like 100 plus kilograms and so on. So, about these devices. For example, I'm not sure if I'm able to show that on the camera generally. So it does say that it's a number 5, size 5 here, and it says that it's for adults for 70 to 100 kilograms. And this is the pressure that you create inside the cuff. More on that right now. So you must deflate everything before you install it in the patient. Then this will be the inside part, and this is the connector from the outside. When you just also push it deep down in the patient, as deep as you can, so you will be left with something like that coming out of the patient. And then you inflate the cuff. When you do that, you will also see the outcome generally the same as before, as in the laryngeal tube. So this part will seal off the esophagus, this part will seal off the mouth, and this is the exit part for the air, so that the air will come inside the airway of the patient. Also, our mask has a unique feature which allows us to use it more securely. So this is a pressure controller, and you see that it has 3 colored levels. So green is the ideal where we are going, and when we start to inflate it, when we're inside the patient, so let's imagine it's compressed somehow, so this pump must stop at the green stripe, so that means that the pressure is okay for the prolonged stay, so the patient will be saved. If the pressure is too high, we'll see something like that, so it will be completely compressed. And in normal relaxed condition, you see that it's on the yellow level, so nothing is compressing and there is no pressure on the distal part of the cuff. So if we don't have it, we can have some additional tool that is attached here on this side, and it will measure the pressure manually. Unfortunately, we don't have it right now. Then this could be enough, but somehow some rescuers managed to intubate patients by accident with these 2 tubes, and this is of course bad. For example, if you intubate patient with this tube, you will seal off the trachea with the distal cuff, and the patient will not get any ventilation at all. For those lucky men, they have invented an additional tube. This is called the Combi tube, or the combined endotracheal esophageal tube. With this one, you also use it blindly, push it inside the patient, and you see that it has 2 entryways. One Number 1 is blue, number 2 is white. Blue is usually associated with oxygen in case of emergency medicine. So in this case, we suggest that by default, we will ventilate patient in number 1. So ideally, when we push it down, it comes to the esophagus, then we inflate 2 cuffs. There are 2 cuffs inflated separately in this case. But when they are on, we will get the same idea where we had here in this tube. So that the air will come here in line 1 and it will come out here on this exit point, and it will get inside the airway. But if you somehow manage to intubate the patient and get this part into the trachea, in this case it will not work. So you try to ventilate it in the line 1, nothing happens, then you say, okay, probably the patient is intubated. Then you switch and start ventilation in number 2, and the exit for number 2 is here on the distal part of the tube. So in this case, when you start ventilation, you will get the same effect that you have in the intubation tube. So this is actually the coolest option possible, but it's not designed for that. But still, you may continue ventilation if the patient was intubated. And that's it for the supraglottic devices. And now we are coming back to the intubation. So you see that it's a rather plain device, but to use it, we must have a special skills, we must have special equipment and personnel. Now, in the words, to do the intubation, we must have a laryngoscope. There are multiple types of these devices. This is one of the basic that you will see in adult hospitals. It has 2 parts. This one is a handle, it has batteries inside. This one is the blade, they are connected together. Blades can be single use, like for example this is plastic single use blade, or they can be multiple used and they are sterilized afterwards, of course. Then when you turn it on by just opening the blade, you start to see the light, because it's dark inside the patient and you do need to see the light. In some devices, it's not only a light but a camera, and they're called the video laryngoscopes, where you don't have to look inside the patient, but you see everything on the screen. There are curved blades like this, there are straight blades. You may see that there are also different sizes. For example, this is number 4. There are 5 general sizes of blades. So this is one for large adults, but not the largest ones. The size and type of blades depends on the situation. Usually we use curved blades in adults and straight blades in children, but that generally depends on the experience and just the general habits of the doctor. So every blade is all right if you know how to use that. And also this is, comes to all the airway management. Every airway management device is useful and okay if you do know how to use that. Now, this is for the tubes, also for the devices that we use for ventilation itself. We can use the face mask, of course. We can use it without any device, just applying that on the face of the patient. And we can use that together with the oropharyngeal tube. You see that it doesn't have a connector which is present in other devices. That's why we can only ventilate patient with this device using the face mask. The face masks are also of different sizes. Generally, this is one of the standard ones for adults. This part, upper part, the more shallow, yes, is for the nose. The lower part is for the jaw. Here we connect the bag or the ventilation tubes, and that's the way that we apply that. I will show you on the patient more on how do we carry that so that it will not leave out any air. And there's also a ventilation bag. Here how it looks, just for storage. Now we can spread it so it will work fine. And by pressing the bag we get the ventilation. Here is the out port for the air. It gets the air from this part, gets air into this part. We can also attach oxygen if we have to, due to some need of ventilation during cardiac arrest, for example. If we want to give additional oxygen, we can use the O2 tube here, and in this case it will mix the air and oxygen together and create some enriched mixture. And the connector is universal, so we can easily connect it to the face mask, or we can easily connect that to any type of the airway management tube. They are all the same. There is no any like special curves, special maneuvers for that. You just press it and it's done. And we can use also the machines for ventilations. They also are using the same connectors, but the machines are a different story. We should not talk about that. And also, when we're speaking for the airway management, we have to discuss the aspiration devices. When we see something, generally some liquids inside the patient, maybe blood, saliva, foam, or vomiting masses, or mixture of listed above. In this case, we have to clean it up. And to clean up the liquids, we have the aspiration devices. They may be manual, they may be driven by hands or by foot, or we can use the electric ones. Here is the example of the electric aspiration pump. Of course, also there are many models, but usually this is the compressor. Here it turns on. They have a ball to collect all the stuff that we get outside the patient. So this is the general tube, and this is the aspiration catheter. We should concentrate on this thing. They are, of course, of different sizes. This one is one of the largest. They are generally smaller. But also they may have some exclusions. This is a distal part that goes inside the patient. You see that it has a hole on distal part and several holes, in this case 2 holes on the sides. This is to prevent it from just sucking up to the wall of the patient. So this will lead to the decrease of function of the device, if just will stick itself into the wall of patient, and also it will damage the tissues that it sticks to. So this is the proximal part. We attach that to the tube, and you see that nothing happens. That's why, because it has a spare entryway for the air. This is for our manual control. So we don't pump every time. So the compressor is on, the device is working. Now I get my tube inside something that I need to clean, and then as soon as I'm there at my destination, I just use my finger to close this entryway, and now it starts pumping from the below part. So in this case, we don't stick to anything. We do not suck the patient tissues up, and we can get it as deep as possible. We can navigate the device, and we can always just manually control when we want it to pump. That's a good thing for control. Not every catheters have something like this. Some aspiration devices, for example, like in the dental practice, they can use buttons for electric control of the compressor, or they may use the floor pedals to control the pumping with the feet. So this is also really different. And now, when we are familiar with all the devices, we should look at how do we install them. So now let's try to use all these airway management devices. First of all, the face mask. To use it, we will have to open the airway of the patient every time, just as we do in the basic life support. We will do it like that. So this we will evade the tone slippery. Then we apply it on the face, so the small part up, the big part down. And now we position our hand so that the fingers will form a letter C. So 2 fingers go up and other fingers are going under the chin of the patient. So this is the way to seal it completely, so that the air will not come to the sides, but will come inside the patient. Now we attach the bag and we use it for ventilation. You can see even now that the chest is rising when I do that. Now the oropharyngeal tube. This will be positioned like that, but to insert it inside the patient, we must bypass the tongue, so we will have to rotate it 180. We open the mouth of the patient, get the tube inside, insert it halfway, then we rotate it back and keep pushing it forward until it's fully inside on the level of the teeth. And now, as you can see, there is no connector. We'll have to use the face mask again. Letter C, press it down, keep it, and ventilate. Now we don't have to do this maneuver, the open airway, because we have already installed the tube, and now we're not worrying about the tongue slippery. To remove the tube, we just pull it out without any maneuvers. Now, the laryngeal tube. We open the mouth of the patient, we can compress the tongue if needed. Then we just, without any really big force, but still directly, we push the tube down the patient until it stops. Then we take a syringe. Then we inflate the cuffs. On all the airway tubes, we have this some type of indicators. So you see that now it's inflated, and we believe that the cuffs are inflated too, but we can easily compress it with our 2 fingers. That means that the pressure is not too much, and it will not cause additional damage for the patient. Now we can attach the back and ventilate the patient. For the long stay of these tubes, we have to fix it. There are special fixation devices, but if they are not, you can just use normal bandage to just strap it around the head and tie here, so it will stay on this position and it will not go anywhere. To remove the device, we have to firstly remove all the air from the cuffs. And then also, without any special maneuvers, we just remove it. Now about the laryngeal mask. As I've said before, we firstly have to remove all the air, or it will not fit. Then open the mouth and get it as deep as possible inside the patient. If the patient's mouth is small, you may damage the cuff with your, not your, but patient's teeth, so try to avoid that. When we're inside, we use this specially designed cuff to get it into green area, and also we can attach the back and ventilate. And you get the idea how do we remove this tube. For the Combi tube, absolutely the same. Also get it down inside the patient. Now these cuffs are small, so we don't have to use a large syringe, but we may if we need. So we inflate both of these cuffs. See that they're inflated. You can even see that there is a volume that you need to inflate them. So it's up to 85 and 12 milliliters. And now we start with the blue port with number 1, ventilate. We auscultate and we see if the chest is rising, so if we are positioned correctly, we continue ventilation with number 1. If we see that nothing is happening, then we switch to number 2. It has the same connector. Right now the device is positioned correctly, that's why I have a huge resistance here on number 2. I cannot ventilate, but I don't need to as long as I have a normal airway access on number 1. Also don't forget about fixing the tube with bandages or with special fixation devices. And now we proceed to the intubation. So this is the hard one. We open the airway. At best, if we have an assistant for us to give all the stuff, but we can do that on our own too. We just have to prepare everything. So we open the laryngoscope, we open the airway, open the mouth, we place the laryngoscope inside the patient, and in case of curved blade. We do that to the epiglottis, but without involving the epiglottis, so it must be hanging freely. And here on the mannequin you will see that there is a really large hole inside, so you see that there is a maybe like that. So you see that I am in the vallecula, which is the space between the tongue and the epiglottis. Then you see the half moon shaped epiglottis, which is hanging freely, and under it there is a big hole, and right now you cannot see that actually, but it does have something resembling the vocal cords. And now I'm taking the tube and I am placing it between them inside the hole. Then I remove the laryngoscope, then I'm removing the introducer, which is a wire that is used to give it more sustainable shape. It's created, this is metal wire, can also be plastic, doesn't matter. So I am inside the trachea, then I take the syringe and I inflate the cuff, then I insert the bag and start ventilation. Now we see that the chest is rising, but we also have to check if we are correct in several ways. Basically, we use the auscultation. We can also use the capnography to see if it's an air from the lungs but not from the stomach. And then we keep ventilating the patient, and if everything is normal, then the saturation will go up, so the respiratory function will be compensated. We can ventilate the patient manually with the bag, or we can ventilate him using the artificial ventilation machine. Now, in this case, we do need the verification because this manipulation requires the precision. So if you miss, if you get in the esophagus and not in the lungs, you will not get any respiration, and you will just ventilate the stomach. Of course, it's not well for the patient. That's why we do have to check. Actually, we have to check every time, but now it's even more vital than usual. And also to remove the tube, we deflate the cuff, then we just extract the tube. You can do that without the introducer or with the introducer. This is actually dependent on the anatomy of the patient, on the nature of the situation, on your habits. So this is also up to a professional responsible for intubation. Now, who does the airway protection maneuvers? Actually, anyone can use the face mask, anyone can use the oropharyngeal tube. Other tubes are a part of more specialized care, more advanced life support, but still they say that everybody who is properly trained, and nobody is saying what does that mean on law, on paper, what does mean that you are properly trained. But if you are trained, then you can use all these devices. Generally, we have the intensive care specialists, and we have special rescue ambulance and so on, which are highly trained in acute care, and they're responsible for the intubation. And if it's not available, then we use some supplementary devices. They say that the closest alternative to the intubation is the position of the laryngeal mask. So if you're not a specially trained medic for the intubation itself, then this is your top choice. This can provide prolonged and right ventilation of the patient until a special team arrives and they decide if they want to replace it. And also, we don't do the intubation every time because it's long manipulation. Right now on the mannequin it took only several seconds, but patients may look different and the situation may be much more worse. And in this case, the intubation will not be possible, for example, from the first attempt, or will not be possible at all. That's why if we, for example, in cardiac arrest and we are short on staff and we cannot waste time on just doing all that stuff, we can not use the intubation, but we can replace it with another tube, so just to save us some time. And of course, when we are ventilating, we're using oxygen, which comes from the console on the walls, or may come from the air tanks in case of ambulance or some kind of field care. This is also something that you have to consider all the time to provide the patient with the best possible air quality when we're talking about the acute care. Okay, that's it for now. Now you know almost everything about the airway management, but remember to practice daily. Only in this case you will be a professional in these maneuvers. So good luck then, and see you next time. Goodbye.